A couple lower yield things we're going to go over really quick is gastroparesis. So how gastroparesis works is that you have neuron damage, and that prevents you from appropriately from your body from using peristalsis appropriately. And so what's going to happen is that food will just build up in your stomach instead. So you can imagine the food's usually going around here, but in the case of gastroparesis, this whole cycle gets slowed down. And usually, why would you have this nerve damage causing this? Usually it is because of diabetes, chronic diabetes. We know diabetes can affect your nerves in several areas. That's why people usually have diabetic neuropathy. But over time, it can actually form uh, gastroparesis through some of the same mechanisms. Some medications can also blunt your nerve response or cause nerve damage. And how it presents is you're going to get abdominal pain after eating, which makes sense because all that bolus of food you had isn't progressing normally through your GI tract. It's getting stuck in certain areas. So you can get nausea and vomiting too for that same reason. And you're usually going to be full quicker than you think because there's nothing else moving along because the food's just sitting in your stomach. Two treatments that we have for gastroparesis are somewhat important to know. You should know that metoclopramide is a dopamine antagonist, and that can help promote gastric emptying. But as with most dopamine antagonists, you have to worry about the side effects. So you can get Parkinson side effects. The whole disease of Parkinson's disease is a decrease in dopamine, so it makes sense that this may cause metoclopramide may cause Parkinsonian side effects. You can also get other central nervous system symptoms like seizures, depression, and drowsiness. And just remember that metoclopramide, you don't want to use this if somebody has a small bowel obstruction because then you're just going to be pushing more food into that obstruction and you can cause a perforation. Erythromycin, on the other hand, is a macrolide, and how it works is it binds to motilin receptors to increase activity in the gut. And we talk about motilin receptors in the small intestine lecture. Okay, the next section we're going to talk about is post-gastrectomy complications and dumping syndrome. So what is a gastrectomy? A gastrectomy is a surgical removal of either a portion of the stomach or the entire stomach. And it's usually elective due to obesity, or you can maybe have to have a region removed because of a tumor. So complications, you can get pernicious anemia, as we've discussed before. And that's because you're losing intrinsic factor because you don't have enough parietal cells. And people who have gastrectomies often receive B12 injections because they don't have enough intrinsic factor to absorb it by mouth. Another complication of gastrectomy is something called dumping syndrome. So we'll talk about that now. So dumping syndrome, how it works is that the stomach normally acts as a reservoir so that only small portions of food can get into the intestine at one time. So you have some food coming in, and then little boluses can enter the duodenum, and everything's fine. The problem is that if you don't have that big of a stomach, sometimes you can have large boluses enter the intestine at once. And so you can get a large bolus of food in the intestine. And what's the problem with that? Well, there's a few different problems. First off, because you have such a big bolus of food or products in your intestine, it can actually draw water into the lumen. And what will happen is that if water comes into the lumen, you're going to have excessive diarrhea. You can also get abdominal pain and nausea from this. Another characteristic of dumping syndrome is that you'll get classically vasomotor symptoms. So you might have sweating, you might have palpitations, high heart rate. And why this is happening is because you're getting such rapidly decreasing intravascular volume. Because remember, all that water is just flowing into your GI tract through that osmotic gradient. And because of that, you can actually get these vasomotor symptoms as well. And so you need to treat this for people who have had a gastrectomy. A good way to treat this is to decrease your meal sizes and also decrease the amount of simple sugars because those simple sugars it's easier for sugar to get inside your duodenum and cause this problem that we just talked about. All right, our last clinical condition is going to be on pyloric stenosis. So pyloric stenosis, the pathogenesis is you have hypertrophic pyloric musculature that causes a pyloric outlet obstruction. Okay, so normally here's our pylorus. You have food, you can open up, the food can get through. The problem is that if you have a hypertrophic pyloric musculature, there's no way for any of the food to actually get through and into your duodenum. So it gets stuck, and sometimes it has to go back up. So this is going to present with either a firstborn male with a failure to thrive. You might also see this classic non-bilious projectile vomiting between 2 to 6 weeks of age. I go into bilious versus non-bilious vomiting in the small intestine lecture, but just know that bile is secreted in the small intestine. So if your bolus of food can't even make it to the small intestine, you're going to get what's called non-bilious vomiting. This might present with an olive-shaped epigastric mass on test day. I've talked to, let me think, I've talked to at least 3 pediatricians, and nobody's ever felt an olive-shaped epigastric mass before, but it's something to keep in mind. And you might see visible peristaltic waves as well. So how do you diagnose this? So you're going to diagnose this. One way to do it, or to give you a higher clinical suspicion of pyloric stenosis, is you might see this classic hypokalemic, hypochloremic metabolic alkalosis that we talked about earlier. And as a quick recap, you can see this in several diseases that involve severe vomiting. And what happens is that the hypokalemia is because you're losing so much volume, your kidneys try to save some of your volume by reabsorbing sodium, but they do that at the expense of potassium. So you're going to be hypokalemic. And then obviously the hypochloremia makes sense because you're losing chloride. The metabolic alkalosis should make sense because you're losing hydrogen at the expense of chloride. On ultrasound, you're going to find a thickened pylorus. So here's an ultrasound, and I'm just going to highlight one part of the wall. You can see the other part below, but it's a very thick pylorus. And how do you treat this? So this is where they get you on test day. You need to correct the electrolyte abnormalities first, okay? Once you've done that, then you can surgically correct it with a pyloromyotomy. I really want to emphasize this because I missed a question before on this. It's very tempting to just put pyloromyotomy, but if somebody's extremely hypokalemic, you cannot safely take them to surgery yet. You should get that corrected. And then once that's corrected, then you can proceed with the surgery. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.